Dear friends, colleagues, my name is Andreas Baumbach. I'm an interventional cardiologist in London, UK. I'm here with Giulio Stefanini from Milan. Milan, of course, being one of the first and worst hit areas in the COVID pandemic. So Giulio brings a lot of experience in treating and diagnosing these patients. We have heard a lot about the difficulties we face when treating patients with ST elevation myocardial infarction in the time of COVID. In this video, we will discuss the specific problems of making the right diagnosis for patients. We'll talk about their symptoms, their ECGs, the troponins, alternative diagnosis, and the role of echocardiography. Giulio, we heard the phrase STEMI mimics, i.e. looking as if there was a STEMI. When did you first realize that there is an issue with diagnosis of STEMI in Milan?
We realized this already in the first couple of weeks of the epidemic. As a matter of fact, we observed some patients with ST elevation presentation, which were also COVID positive, who did not have a culprit lesion. And there we decided to collect the regional experience from the entire Lombardy hospitals, observing in a case series that almost half of these COVID-19 patients presenting with ST elevation MI do not have a culprit lesion at the coronary angiogram.
That is interesting. So they go to the cath lab, but they don't have a STEMI. Do patients experience different symptoms from a normal STEMI?
Well, no, symptoms are the same for ST elevation MI patients. But we need to consider that patients with COVID pneumonia also have dyspnea and chest pain, which complicates the diagnosis.
And just to confirm, you're saying that we do see ECG changes, including ST elevation MI patterns in patients with the COVID infection?
Yes. In our experience, we observed a significant number of patients with ST elevation MI. Of note, actually, this was the first clinical manifestation of COVID infection in the large majority of patients included in our case series.
So that's also patients coming from the outside, not just patients in hospital with COVID infection. That's interesting. Do you have a diagnosis for these patients? This is all myocarditis?
I think that it's a bit more complicated. There are a number of mechanisms that may play a role. It could be myocarditis, but also type 2 MI or endothelial dysfunction, or also the result of a cytokine storm.
So we usually base the final diagnosis of STEMI and non-STEMI on troponins, but we know for the COVID scenario that mild troponin elevations, as we've seen in Wuhan, are quite frequent, and also excessive rising troponins are related to bad outcomes in severely ill patients. So is there any way of differentiating the proper, what we call type 1 MI caused by a coronary obstruction from all the other myocardial injury patterns?
Well, in patients with ST elevation presentation, it's very difficult without a coronary angiogram.
A lot of people seem to think that echo can help. Can echo really help us making the diagnosis in practice?
Well, I think that echo could be useful. However, it's very impractical in these patients. As a matter of fact, we need to consider two large groups of patients suffering from ST elevation and COVID-19. So there are patients that are already hospitalized, and those are a minority. Actually, an echo could be organized with all the required protective measures. On the other hand, we have patients presenting at the emergency department with ST elevation MI, for which the COVID status is initially unknown. The organization of an echo in these patients, it's a bit more complicated in the acute setting.
The other issue that always comes up, it's not so much about diagnostics, but it's about treating patients. So we have to get the diagnosis right. When would you decide to thrombolyze a patient?
If a timely primary PCI cannot be achieved, taking into account that COVID-related reorganization may determine an extra delay up to 60 minutes, well, in these cases, we should perform thrombolysis.
So should we or should we not change our practice in the height of the crisis?
I think that it very much depends on the intensity of the pandemic in a specific region. If the healthcare system is marginally involved, all efforts should be made to provide regular guideline recommended strategies. Conversely, in case the healthcare system is heavily involved, we should limit the access of patients to the cath lab with a more restrictive approach.
But just come back to STEMI and STEMI presentations from the outside. Are there any patients that we can identify that do not need to go to the cath lab?
Well, I think that we should consider two groups: patient already hospitalized with COVID pneumonia and patient coming from outside to the emergency department. In the latter group, we need to perform an angiogram, and it's not possible to differentiate.
Thank you. I think you made that point very clear, and I think we're coming to that conclusion on through various paths. Thanks for this interesting conversation. I'll try and summarize the main points here. As it comes to symptoms, somebody with an ST elevation, myocardial infarction, COVID or not, will have the typical symptoms, but we have to appreciate that COVID pneumonia itself leads to dyspnea and often chest pain. We have ECG changes that can look ischemic, even ST elevation MI patterns go with the COVID infection. Troponins, we see mild elevations quite regularly and severe elevations also in severely ill patients, but the usual patterns of a steep rise of troponin in standard type 1 MIs is still there. The echo can be helpful if it fits the pattern of wall motion abnormality that would suggest a region is infarcting, but it can be difficult to organize in this time of crisis. And I think we made it very clear thrombolysis should only be considered in typical MI and only if there is a long delay in the provision of primary PCI. And it's very difficult not to take patients from the outside with ST elevation MI to the cath lab, because whilst we know there is a good number of patients with normal coronary arteries due to the COVID infection and related patterns, it is very difficult to decide on the spot that somebody doesn't have an obstructed coronary artery. So yeah, acutely, they probably will all still need to go to the cath lab. So this brings us to the end of this video. There are other videos out there with more practical information on STEMI management on the Facing COVID-19 with PCR webpage. Giulio, I thank you again for this conversation. Thank you for listening in, and all stay safe.
Thank you. Goodbye.
Goodbye.